Hello, this is Anudeep, a second year medical student. May I know your name, please?
Yes, I'm Raju,
May I know your age?
19 years.
Okay, do you find any kind of difficulty in breathing?
No,
Do you have any chest pain?
no,
Or do you have any cough?
no.
Okay, today I'll be going to examine your both anterior as well as your posterior thorax. It might cause a little bit of discomfort. Will that be okay with you?
Yes, I'm okay.
Okay, fine. We'll start in a couple of minutes. Can you please take off your shirt, please, so that I can easily visualize your chest?
Yes, okay.
Yeah, thank you. Now ask your patient to gently inhale and exhale while you measure his respiratory breaths by using your watch. Even though the respiratory rate might already been recorded, again carefully observe for rate, rhythm, depth and effort of breathing. A healthy resting adult breathes quietly and regularly about 20 times a minute. Note whether expiration lasts longer than usual. Now ask your patient for the examination of nails. Note for any kind of color and any kind of abnormalities on nail beds. Repeat the same for the other hand as well. Now it's time to check regarding the clubbing of the fingers. Look for the diamond shape between the two nails. Generally, clubbing may result from chronic low blood oxygen levels. And now, ask your patient to inhale and exhale while you examine his neck movements, especially the muscles of the sternocleidomastoid and also the skeleton muscles. And also look for the tracheal deviation. Now it's time for palpation of chest. As you palpate the chest, focus on the areas of tenderness or bruising, respiratory expansion and fremitus. Identify tender areas. Carefully palpate any area where the patient reports any pain or any visible lesions or bruises. Note any palpable crepitus defined as crackling or grinding sound over the bones, with or without pain due to air in the subcutaneous tissues. Now test for the chest expansion. Place your thumbs at above the level of 10th ribs with your fingers loosely grasping and parallel to the lateral rib cage. As you position your hands, slide them medially just enough to hold a loose fold skin between your thumbs over the spine. Ask the patient to inhale deeply. Watch the distance between your thumbs as they move apart during inspiration and feel for the range and any symmetry. This movement sometimes is called lung excursion. And now, it's time for palpating fremitus. Ask the patient to repeat the words 99 or any 11. To detect the fremitus, use either the bony part of the palm or any kind of ulnar surface of your hand to optimize the vibratory sensitivity of bones of your hand. Ask the patient to repeat the words 99 again. Use both of the hands to palpate and compare the symmetric areas of lungs. Now it's time for percussion. With your flexor or striking finger, use the lightest percussion that produces a clear note. A thick chest wall requires a more forceful percussion blow within a thin one. However, if a louder note is needed, apply more pressure with a pleximeter finger. Percuss one side of the chest and then the other at each level in a ladder-like pattern. Omit the areas over the scapula. The thickness of the muscle and bone alters the percussion notes over the lungs. Identify and also locate the area and quality of any abnormal percussion note. Diaphragmatic excursion. First, determine the level of diaphragmatic dullness during the quiet respiration. Now, percuss it downwardsly in progressive steps until dullness clearly replaces resonance. Now, estimate the extent of diaphragmatic excursion. Normally, the gap will be around 3 to 5.5 centimeters. And now, it's time for auscultation. Use the ladder pattern suggested for percussion, moving from one side to the other by comparing symmetric areas of lungs. Note the intensity of breath sounds which reflects the airflow rate. Learn to identify breath sounds by their intensity, their pitch, and relative duration of inspiratory and expiratory phases. Normal breath sounds include vesicular or soft pitch. These are generally low pitch sounds. They are heard throughout the inspiration, continue without pass through expiration, and then fade away about one third of the way through expiration. Next is bronchovesicular, with inspiratory and expiratory sounds about equal in length at times separated by silent interval. Detecting differences in pitch and intensity is often easier during expiration. Next one is bronchial or louder. With a short silence between inspiratory and expiratory sounds last longer than the inspiratory sounds. If you find any kind of abnormalities, and then go and find for the adventitious added sounds. And now, if you hear any kind of abnormalities located in bronchovesicular or bronchial breath sounds, assess transmitted voice sounds. Detection of adventitious sounds, crackles, wheezes, and bronchi is an important focus of our examination. Now ask the patient to say 99. Normally the sounds transmitted to the chest wall are muffled and indistinct. Louder voice sounds are called bronchophony. These bronchophony louder sounds reflecting the transmission through airless tissue. And now it's time for egophony test. Ask the patient to say E. If E sounds like A and has a nasal bleating quality and E to A change, then egophony is present. You'll normally hear a muffled long E sound. And now ask the patient to whisper 99 or 123. This is a test for whispered pectoraliqui. The whispered voice is normally heard faintly and distinctly, if at all. Louder, clearer whispered sounds are called whispered pectoraliqui. So that completes this test. While examining the anterior chest, patient should be laid in a supine position comfortably with arms somewhat abducted. Observe the shape of the patient's chest and the movement of the chest wall. Note for any kind of deformities or asymmetry of thorax. Assessment of chest expansion. Place your thumbs along each costal margin, your hands along the lateral ribcage. As you position your hands, slide them medially a bit to raise loose skin folds between your thumbs. Ask the patient to inhale deeply and observe how far your thumbs diverge as the thorax expands, and feel for the extent and symmetry of respiratory movement. And now, assessment of tactile fremitus. If needed, compare both sides of the chest using the ball or ulnar surface of your hand. Fremitus is usually decreased or absent over the precordium. When examining a woman, gently displace the breast as necessary. And now, percussion. As needed, percuss the anterior and lateral chest. Again, comparing both sides. The heart normally produces an area of dullness to the left of the sternum from the third to fifth interspaces. In women, to enhance the percussion, gently displace the breast with your left hand while percussing with the right, and ask the patient to move the breast for you. And now it's time for auscultation. In auscultation, listen to the chest anteriorly and laterally as the patient breathes with the mouth open and somewhat more deeply than normal. Compare symmetric areas of lungs using the pattern suggested for percussion and extending it to adjacent areas if indicated. Listen to the breath sounds, noting their intensity and identifying any variations from normal vesicular breathing. Breath sounds are usually louder in the upper anterior lung fields. Bronchovesicular breath sounds may be heard over the large airways, especially on the right. And now identify for any kind of adventitious sounds and locate them on the chest wall. So this completes the test. So that completes the entire procedure and everything is normal. Thank you.
Okay, thank you.